Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about Discoid Lupus Erythematosus. Definition: Discoid Lupus Erythematosus or DLE is one of several rashes that can occur in lupus. DLE is a rash that scales and scars. Immunoglobulins are found in the skin in this autoimmune disease. Clinically, the lesions appear as duck-shaped plaques surmounted by a white adherent scale that also involves the hair follicles. Discoid lupus erythematosus may be limited to the skin, or it may be one of the manifestations of systemic lupus erythematosus. Note: Discoid lupus erythematosus may be limited to the skin or may be a manifestation of SLE. Incidence: the disease affects primarily young and middle-aged adults and is 2 to 3 times more common in females than males. It is uncommon, but the exact incidence in the general population is not known. In one observation of all the new patients coming to a dermatology clinic, 2 per 1,000 were seen for Discoid lupus erythematosus. History: the eruption may be slightly pruritic but is more often asymptomatic. Patients may give a history of exacerbations after exposure to sunlight. In patients with Discoid lupus erythematosus, a history should be taken for symptoms of possible systemic lupus erythematosus, including photosensitivity, hair loss, nasal and oral ulcerations, Raynaud phenomenon, arthritis, and other extracutaneous organs. Physical examination: the earliest lesion is a purplish red plaque which accumulates scale as it matures. The scale is white and usually cohesive, so it can often be removed in one piece. When this is done, the underside of the scale may show small spiny projections. These have been called carpet tags, and they represent the keratinous plaques that had been present in dilated hair follicles. The oldest lesions appear as depressed atrophic plaques, often with pigmentary change, usually hypopigmentation in the center with a hyperpigmented rim. Discoid lupus erythematosus: a red and whitish scaling atrophic plaque with hyperpigmented or darker brown border. In epidermis, hyperkeratosis with follicular plaguing and color degeneration of the basal cell layer is present. In dermis, perivascular and periappendigeal inflammatory cell infiltration is present. The distribution of the DLE lesion favors sun-exposed areas like face, neck, upper trunk, and dorsal arms. An occasional patient has widespread cutaneous involvement. Erosions in the oral cavity, particularly of the palate, are occasionally found in patients with Discoid lupus erythematosus. The scalp is frequently involved with scarring alopecia. Discoid lupus erythematosus: early lesions showing erythema and scarring, late lesions showing hyperpigmentation and hypopigmentation within scarring, alopecia in dark skin. Differential diagnosis: psoriasis may be the most common misdiagnosis. The finding of atrophy helps to differentiate the two. Lichen planus lesions are also purplish, but they are usually small, papular, have a scant scale, and do not result in depressed scars. The scaling patches and plaques that occur in subacute cutaneous lupus erythematosus or SCLE also do not scar. Frequently they are annular and are often accompanied by circulating anticytoplasmic antibodies like anti-Rho or SSA and anti-Lo or SSB. Superficial fungal infection, sarcoidosis, and granuloma facial may be considered in the differential diagnosis and will be confirmed with a potassium hydroxide or biopsy. The conclusion of differential diagnosis of Discoid lupus erythematosus include psoriasis, lichen planus, subacute cutaneous lupus erythematosus, fungal infection, sarcoidosis, and granuloma facial. Laboratory and biopsy. Skin biopsy establishes the diagnosis. In addition to the history and physical examination, a laboratory screen for systemic lupus erythematosus should be done on all patients with Discoid Lupus Erythematosus. This includes a complete blood cell count, a renal function panel, a urine analysis, and an anti-nuclear antibody or ANA test. If the latter is positive, an anti-double-stranded DNA antibody test should be ordered. Patients with Discoid Lupus Erythematosus who have positive ANA test or persistent complete blood cell count abnormalities are more likely to develop systemic lupus erythematosus subsequently. Note: patients with Discoid Lupus Erythematosus should be screened for systemic lupus erythematosus with complete blood cell count, renal function panel, urine analysis, and anti-nuclear antibody test. Therapy. Topical therapy is usually adequate. Steroids applied topically or injected intralesionally are used most often. Sun protection is important, and sunscreens that protect against both short ultraviolet B or UVB and long ultraviolet A or UVA light should be strongly recommended to all patients. Patients with extensive or recalcitrant disease sometimes require systemic therapy. Antimalarials such as chloroquine 250 mg daily or hydroxychloroquine 200 to 400 mg daily are used most often. Patients receiving these antimalarial drugs should undergo ophthalmologic examination at baseline and then annually after 5 years of use, or yearly from the start if major risk factors are present. This is to monitor for the retinal toxicity that is rarely encountered with the dosage used in Discoid Lupus Erythematosus. For patients with Discoid Lupus Erythematosus not responding to the above measures, alternative systemic therapies including retinoids like isotretinoin or acitretin, dapsone, thalidomide, azathioprine, mycophenolate mofetil, methotrexate, and oral gold may be used. The conclusion of therapy for cutaneous lupus erythematosus: initial therapy includes topical steroids like clobetasol cream 0.05% BID, sunscreens, and sun protective clothing. Alternative therapy includes antimalarials like hydroxychloroquine 200 mg BID or chloroquine 250 mg daily, retinoids like isotretinoin or acitretin, thalidomide, azathioprine, mycophenolate mofetil, methotrexate, dapsone, or gold. Course and complications. The course of the disease is chronic, but with therapy usually controllable. New lesions may continue to appear over the course of years as old ones become inactive. Eventual remission occurs spontaneously in approximately 50% of patients. Scarring and post-inflammatory hypopigmentation and hyperpigmentation are common and may result in disfigurement, particularly in black patients. In the scalp, the scarring leads to permanent alopecia. If extensive, this can be a cosmetic problem. In patients presenting with only Discoid Lupus Erythematosus lesions, the risk of subsequently developing systemic lupus erythematosus is 5 to 10%. Note: about 5 to 10% of patients presenting with Discoid Lupus Erythematosus subsequently develop a systemic lupus erythematosus. Pathogenesis. Lupus erythematosus has been classified as an autoimmune disease because of the autoantibodies found in the disease. In Discoid Lupus Erythematosus, these are in the form of IgG and IgM deposited in the dermal epidermal junction. The cause of this deposition and the role that these immunoglobulins play in the pathogenesis of the skin lesions are not clear. UV light has been implicated as a pathogenic factor. Circumstantial evidence for this includes the localization of lesions mainly in sun-exposed areas, the finding that many patients note that sun exposure exacerbates their skin disease, and the experimental induction of skin lesions with UV light. A sequence of pathogenic events has been proposed as follows. UV light damage epidermal cells, releasing their nuclear antigens. These diffuse to the dermal epidermal junction, where they combine with antibodies from the circulation, initiating an inflammatory reaction, resulting ultimately in the clinical lesion. T-cell dysregulation has also been implicated in the pathogenesis of cutaneous lupus. For example, increased activity of the T helper 2 subset of helper T cells has been found in lesional skin. The main function of these cells is to augment humoral immunity. Genetic predisposition to Discoid Lupus Erythematosus is possible, but familial disease and association with specific HLA phenotypes have been reported more frequently with systemic lupus erythematosus than with Discoid Lupus Erythematosus. Current evidence suggests that most patients with Discoid Lupus Erythematosus have a genetically different disease from that in patients with systemic lupus erythematosus, a concept that accounts for the observation that most patients with discrete lupus erythematosus never develop systemic lupus erythematosus. Clinical case: a 34-year-old woman presents with slowly progressive skin lesions on her face and scalp for the past 8 months. The lesions are asymptomatic to mildly pruritic but have left permanent scars in some areas. She reports photosensitivity, noting that the lesions worsen after sun exposure. There is no history of oral ulcers, arthritis, or systemic symptoms. On physical examination, there are well-defined erythematous plaques with adherent scales over the cheeks, nose, and scalp. Removal of the scale reveals follicular plaquing and causes mild bleeding. Several lesions show central atrophy, hypopigmentation, and scarring alopecia on their scalp. Laboratory evaluation shows normal CBC and renal function. ANA is negative. What is the most likely diagnosis? A. Psoriasis, B. Lichen planus, C. Sarcoidosis, D. Granuloma facial, and E. Discoid Lupus Erythematosus. According to our explanations, the correct answer is E, or Discoid Lupus Erythematosus. Explanation: Discoid Lupus Erythematosus is a chronic cutaneous lupus characterized by photosensitive, well-demarcated erythematous plaques, adherent scales with follicular plaquing, central atrophy, hypopigmentation, and scarring is present. Scarring alopecia when the scalp is involved, and usually no systemic involvement and often a negative ANA. While the other options are less likely. Psoriasis is a silver scale, auspicious sign, no scarring or follicular plaquing. Lichen planus is a violaceous flat top papules with Wickham suria, and mucosal involvement is common in lichen planus. In sarcoidosis, non-scaly papules or plaques are present, and apple jelly nodules on endoscopy is present without scarring. And granuloma facial is a red-brown plaques on the face, with a smooth surface and without scale or scarring. Okay, this was an explanation about DLE, or Discoid Lupus Erythematosus. Thank you for your attention.